This is a technique describing endoscopic debridement and repair of proximal hamstring calcific tendinopathy. These are our disclosures. While calcific tendinopathy is well described throughout the body, currently there are no descriptions of calcific tendinopathy of the proximal hamstring. There are several non-operative modalities for management, but if symptoms continue to be refractory, operative treatment is indicated. In this presentation, we describe a minimally invasive endoscopic technique to debride the calcifications and repair the proximal hamstring tendon. The patient is positioned prone on a standard operating table with the head at the foot. There are two arm boards placed at 45 degrees to the patient at the level of the operative hip. The operative hip is abducted and placed on these arm boards. It is crucial to avoid hip flexion as this will obscure the operative field. The first portal is the mid-central portal, which will serve as the main viewing portal. This is created under fluoroscopic guidance at the midgluteal crease right over the ischial tuberosity. Next, the medial and lateral working portals are created under direct visualization with the arthroscopic camera. These should be placed slightly superior to the mid-central portal in order to facilitate a better view with a 30-degree scope. Later in the case, the suture management portal may be created far superior in line with the hamstring tendons to facilitate suture management. After establishing the mid-central viewing portal and clearing out bursal tissue, calcific tendinopathy may or may not be identified at the insertion site of the proximal hamstring tendon. Often, the tendon will appear similarly to a partial thickness tear. As seen here, calcification can be expressed from the tendinous insertion as it is trephinated with an 18-gauge spinal needle. While this technique can help localize calcific deposits, it is insufficient alone to completely debride the tendon. Using an ablator, a vertical opening is made through the tendon insertion and is taken down to bone at the site of calcification or a partial thickness tear. Calcification is then identified and debrided with a reciprocating shaver, which is demonstrated here. You can see the bits of calcium deposition being released into the surgical field. It is important to debride all affected tissue and to establish an adequate bone bed for tendon repair. With good visualization of the bare ischial tuberosity and an open subgluteal space, the lateral portal is established using direct endoscopic needle localization. The final position should optimize access to the entire ischium and subgluteal bursa, as well as the placement of anchors into the ischium. A suture management portal may also be established at this time. 2 or 3 triple-loaded vented suture anchors are then placed into the ischium, depending on the size of the created tear. This is the point at which an interpositional scaffold would be shuttled down the sutures to the bone anchor interface if further augmentation is deemed necessary. Sutures are then passed through the medial and lateral tendon leaves from the medial portal using a retrograde suture passer and antegrade suture passer. After passage through the tendon, the sutures are passed superiorly to improve visualization and to improve suture management. Once all sutures have been passed, they are tied with a standard arthroscopic sliding knot with the knee flexed 90 degrees. We prefer the SMC knot with 2 alternating half hitches. Once these are tied, the knee is relaxed and the repair site can be evaluated. If at this point the surgeon feels that the repair needs more structural integrity, a collagen-based scaffold can be fixed over the repair site. Following surgery, patients will be non-weight-bearing or flat-foot weight-bearing in the operative extremity for the first 2 weeks. This is left up to the discretion of the surgeon, as both methods have had good success. At the week 2 postoperative visit, patient will begin progressing weight-bearing, and physical therapy will start, focusing mainly on range of motion. At the 6-week follow-up, all restrictions will be lifted, and the patient will begin full weight-bearing.